So that was a wonderful first session. Following Roger Glass is very hard act to follow. Obviously, very delighted for his recognition in global work. So good morning. My name is Man Chard. I'm the director for the Center of International Health, Education, and Biosecurity at the University of Maryland, Baltimore School of Medicine. So welcome to our Plenary 1, which is on transforming partnerships with the National Public Health Institute for sustained global health implementation and research. As you know, we're all currently living in the age of pandemics. COVID-19 has taught us a lot, that we are much more interconnected, but also we are all collectively ill-prepared to address emerging and re-emerging infectious diseases. More recently, since 2020, we've seen Ebola, Mpox, measles, to name just a few. And having a robust pandemic preparedness response goes beyond just finding a funding stream. That is just not enough to get funding stream, but perhaps require us to look at and leveraging existing partnerships that is already there purposefully and intentionally. In terms of across multi-sectoral coordination in many of the countries that we work in, the National Public Health Institute plays a pivotal role in health policy decision-making through overseeing surveillance data, but also overseeing public health responses. But historically, the NPHIs have not been, or very limitedly been involved in HIV response. So it is at a critical juncture where it is going to be very important to hear from their perspectives as to how best donors, implementing agencies, academic institutions, as well as NGOs to help strengthen their capacity in science, in service, in prevention, in surveillance. And we'd like to be able to achieve today is having a solution-oriented conversation so that we could guide what else do we need to do to help support the frontline NPHIs so that they can be prepared for the next pandemic. So set the stage for this, it's my pleasure to welcome Dr. Mamadi Yella. She is the Principal Deputy of the U.S. Global AIDS Coordinator and a senior member of the U.S. government team. Prior to joining the State Department, she was a fellow in immunology with a strong focus on diagnostic for vaccine preventable childhood diseases, and now she supports the oversight and implementation of PEPFAR. Welcome, Dr. Yella.
Well, good afternoon, and it is my pleasure to be here. And on behalf of Dr. John Nkengasong and the PEPFAR team, we are really pleased to join you this afternoon. So thank you. So I want to just say a couple of things as a segue, actually, to the folks who are going to be giving longer presentations. And so let me begin by just saying what a pleasure it is to be here on behalf of PEPFAR. And I'm assuming that everyone knows what our acronym stands for, and we don't need to repeat that here. But to set the stage on the importance of national public health institutes in pandemic preparedness, and the lessons the COVID-19 pandemic taught us, and what we're doing with those learned lessons. So you may be aware that the United States over the last 20 years has been at the center of the fight against HIV and AIDS, helping save the lives of 25 million people, largely on the continent of Africa, through the provision of life-saving antiretroviral therapy and other prevention and care services, and investing in utilizing and capacitating the institutions, government entities, and community entities that provide these services. PEPFAR began as a very specific targeted approach to tackle mother-to-child transmission. As our data drove us to populations and places most burdened by HIV, PEPFAR necessarily began to diversify its approach, has aligned with the UN goals of knowing your HIV status, getting on treatment, and suppressing the virus, our so-called 95-95-95 goals. Sustaining progress in the fight against HIV/AIDS has required PEPFAR to modify, inform, and sharpen its interventions over its 20-year history, which has been informed by granular data and real-time policy changes to ensure effective programs. During the COVID-19 pandemic, PEPFAR's infrastructure of labs, lab networks, supply chains, surveillance and information systems, and critically, the health workforce we support in partner countries at the clinics and in the communities proved instrumental in mounting a health security response in partner countries, an unanticipated yet highly effective result of the dexterity of our HIV programming. Post the acute phase of COVID-19, we recognize a continued opportunity to more sustainably integrate these aspects of the health security responses that are innately connected to our HIV work. We have a mandate that meets the moment, and we're leaning in with intentionality. So what is the role that public health institutes can play? I'm going to pick up something Roger said a minute ago about who had direct agreements with our US agencies who implement PEPFAR. As we move into this space with more intentionality, we only have 2 of such agreements in Mozambique and in Ethiopia. So one of our internal targets is to actually raise that number. These are public science-based entities which carry out essential public health functions that are supported by PEPFAR in many partner countries to help end HIV. Often the PHIs are at the center of the institutions who are committed to utilizing and empowering their capacity so that specific functions of laboratory diagnostics, surveillance, public health workforce, research, and emergency response to outbreaks of domestic and global interests are better leveraged to get better outcomes for the people that we serve, particularly those living with HIV/AIDS. So we look for opportunities to learn from this community of partners and colleagues to assist us better utilize PHIs to sustain our gains in HIV/AIDS and concurrently support partner country efforts for health security and pandemic preparedness and response. Thank you.
So we have invited esteemed colleagues from both Nigeria and Malawi to hear from their perspective on what capacity building that we can help strengthen. And so for the first speaker, really honored to have Dr. Ifedayo Iditifa, who is the second Director General for the Nigeria Center for Disease Control and Prevention, one of the NPHIs that are in Nigeria. Again, his list of accreditations is pretty long, but I could tell you that he sits at the WHO level for the Integrated Pathogen Network Group and also be leading responses from Nigeria, obviously with the more recent Mpox outbreak, but also Lassa viruses as well. And so really would be welcoming Dr. Iditifa to the podium to share his perspective. Thank you. Welcome. Yes.
Thank you very much to Man and colleagues for inviting me to speak at this event. Just very quickly, I'm assuming this is the pointer, but I hope nothing goes off if I, yeah. Okay, so I thought I would start off by spelling a picture. People are used to seeing this map, but I've put this up to sort of describe a picture of the way I guess myself and many of my colleagues in NPHIs see the world. Is that we see disease outbreaks everywhere you look, and often they don't come according to a timetable, and they are frequently concurrently occurring. So this is what this looks like, and in my part of the world, which is in the middle there, we're probably responsible for the large font size for cholera and monkeypox, among other things. But beyond diseases, we've got issues like this ones. So as I've said, multiple diseases, but you've got flooding, you've got challenges with livelihood, and basically what we call a situation of polycrisis, which requires you to be able to pivot quickly and often to fight wars on multiple fronts, which sometimes is quite difficult to do. And on top of this, if this is the current scenario, is the future in terms of health security challenges actually predicted to be bleak. So we're expecting challenges that would come as a result of climate change. And depending on what aspect of climate change you look at, but if you choose the narrow window of diseases, whether they are mosquito-borne or otherwise, or those that result from what would be the increased interactions between humans in the environment and animals, with the risk of more zoonotic illnesses. Bottom line is we will have more challenges going forward if the predictions are true. Climate change, I've talked about this and all of the various components, and the main consequence really in terms of national security is the risk of emerging and reimagine infections, including those that are epidemic or epidemic prone, or in the pandemic prone, as we have seen with COVID. And this now means that there's, as a fallout of COVID, there is an increased recognition of the role of public health institutes, whether it's the global one, global or continental or national or regional, as the case may be. I think that, there's often a lot of flack, a lot of criticism, but I think the consensus is emerging around the fact that these bodies have utility, and the debate is more about, okay, how do we make them do better, or how do we equip them to make sure that we're in a better place to respond to the next pandemic, because by all accounts, and despite COVID-19, which is still ongoing, and all of the lessons that we are supposed to have learned from the pandemic, the world is still not prepared for the next pandemic. And of course, preparedness will differ by which part of the world you're speaking from. So this is what the scenario used to be, and maybe still is in a number of countries, but we know that there's a drive to have NPHIs across the world. I think what needs to be recognized is that there will be differences in the speed and in the direction of travel as NPHIs evolve. There's the temptation to think of one big model, say like the US CDC or the UK Public Health Security Agency or the European version. But I think what is important and what needs to be recognized is that in every country there will be context-specific adaptation and context-driven growth. But at the end of the day, what we all hope to achieve is that you have some integration in the public health response, and you put all of this under the coordinating responsibility of the country's NPHI, whether their remit is limited to communicable diseases or it includes non-communicable diseases and neglected tropical diseases and so on and so forth. The point at the end of the day is that you achieve integrated public health response. So let's talk about Nigeria and Nigerian CDC. Just like we all know here, this is what we are meant to do: prevent, detect, and control the spread of communicable diseases. I don't know who came up with that idea, but anyway, that's what we're supposed to do. And linked to that is obviously our commitment to having a healthier and safer Nigeria through the prevention and control of diseases of public health importance. And of course, linked to this is everything else under the IHR or the pandemic treaty being negotiated. The point is, countries' IHR responsibilities, and indeed whatever is agreed to in the pandemic treaty, that response or meeting the obligations that countries sign up to would typically be coordinated by NPHIs. I thought I would run through. So in our coordinating role, we are responsible for the coordinating or the implementation of the National Action Plan for Health Security, which is an all-of-government, multi-sectoral endeavor that costs a lot more than what is listed there. And I've sort of given that budget because it's now allows me to pivot to what we're talking about here is we will need multiple streams of income or funding to assure health security in our various countries. We will need to depart from this siloistic or the way we've got vertical disease programs and think a bit differently about the strategy of leveraging all of the opportunities that are afforded by PEPFAR, by PMI, by Global Fund, and all of those into leveraging all of those to serve national health security. It's one thing to focus on, vertical programs are disadvantageous and we need to integrate them, but I think that the idea should be how to achieve cross-cutting synergy, and achieving cross-cutting synergy does not mean that in the drive for health security that NPHIs or other entities suddenly also have to take on disease control or disease control implementing activities. So I don't need, as the Director General of the Nigeria Center for Disease Control, to suddenly become involved in HIV/AIDS control. The colleagues who have been running that for the last couple of decades are very good at doing that, and it's fine. Okay, but what I need to look at or to sort of explore in the conversations is we do need to have a national or a good surveillance system that is integrated across pathogens. So can I leverage your resources for surveillance, for example, or can I leverage your resources again for healthcare workforce and the like? And I will give some examples of those as we go forward. So people often talk about gaps and limitations. In another talk yesterday, I was saying to people that every gap, every challenge actually represents an opportunity, and that's sort of the way I like to look at things. You lament briefly, and then you sort of look to see what you can do about whatever it is you're lamenting about. So what are some of the gaps? Obviously, surveillance is a big one. We all want to be able to, in real time, detect threats as they occur, notify them, and hopefully all of those will lead to an effective response. And I think just yesterday, with colleagues at Resolve to Save Lives, there's the paper that was published on the 717 performance metric for public health, responding to public health response. And the whole idea in terms of the bottlenecks identified, they've identified areas to intervene, which are linked to some of our priorities that are listed here. So let me talk about surveillance specifically. We are keen in our surveillance strategy to have all of these four domains become the norm. So leveraging COVID pandemic response investments, leveraging HIV/AIDS program investments, so TB or malaria. The idea is you need surveillance to be better across board. And if you strengthen genomics surveillance because you are testing for HIV drug resistance, this is cross-cutting knowledge, whether it's wet lab or dry lab or bioinformatics. This also will feed into whatever you do for cholera or for Mpox and so on and so forth. And of course, for some of the diseases like you have for the testing or co-testing, co-management for HIV and TB, working with PEPFAR programs, for example, will allow us to explore, again, what may be the increased risk of mpox, for example, in persons who live with HIV/AIDS. So just to give that as an example. So if we go back 5 years, Nigeria had conducted what was this largest AIDS indicator survey, 100,000 plus survey participants, and all of those samples are currently banked at the NCDC, so we benefited from capacity building for biorepository, which now has us probably with the largest public sector biorepository in the continent, and the facility to do that. In addition, we benefited from a mega PCR laboratory with capacity to run 3,000 samples per day. So this does, at the moment, does not just serve HIV, but it also means, for example, if I had an uptick in COVID, I can, like, assembly line fashion, run samples through the mega lab and have a quicker response in terms of testing compared to just before the diagnosis of the first case, when we had only 3 labs capable of doing making the diagnosis of SARS-CoV-2 infection. So, last few slides. Strategy for me, in terms of responding and intersecting HIV and other pandemics, I think people often forget that HIV is probably a pandemic that has been going on for, I don't know now, 30, 40 years, as the case may be, depending on which time point you choose to look at. So for us, we're currently, one of the models we're benefiting from and trying to build on is this opportunity now through PEPFAR to have strengthened and sustainable laboratory services. I think it's important that I highlight our gratitude to Ambassador Nkangasong for this new philosophy of PEPFAR that allows us to really begin to leverage PEPFAR resources in the service of epidemic preparedness and response, or indeed national health security. And working with, and of course, all of this will entail working with partners, implementing partners of PEPFAR, of the US CDC and other USG entities, and indeed entities from other countries. So APIN, which I think historically is associated with Harvard, is working with us to strengthen our laboratory system to also be able to deliver on our strategy of integrated disease surveillance. We are struggling to have an idea of what the common causes of febrile illnesses are in the country. There's very little work being done typically about diagnosing viruses that may be responsible for febrile illnesses. So we are doing some work with the University of Maryland affiliates, the IHV. And of course, continue to build on HIV/AIDS resources, it's genomic surveillance. The new one for us is the ability to tap into resources for workforce development. It is key that the National Field Epidemiology Training Program continues to run, and in fact, we can expand capacity in terms of numbers trained by through the use of more resources, and of course, bring to bear even further strengthening of our aspirations to have a National Genomics Center in the public sector, using resources that are made available through HIV/AIDS. And I just go on to, it's same thing with malaria and neglected tropical diseases. It's the Global Fund investments, President's Malaria Initiative, and domestic resources through the National Malaria Elimination Program means that we will, of course, be able to provide reference laboratory services in terms of resistance testing or looking at therapeutic efficacy testing. Again, some of that will be done in partnership with MSH, which is another implementing partner. And more recently, our other reference laboratory campus in Lagos will now become a reference lab for integrated testing of both malaria and neglected tropical diseases through funding and the support of the CDC Foundation. So, I think that, and I've said some of this, is certainly as long as you require a multi-sectoral and all-of-government approach to national health security, you must be able to tap into non-traditional sources of funding and support, whether they are vertical disease programs or otherwise. Cross-cutting approaches, as I said earlier, that do not necessarily involve taking on primary implementing activities or responsibilities can provide access to crucially needed technical and financial resources, for example, those that are available within HIV, AIDS, TB, malaria, and other vertical disease programs. And my strategy, our strategy, is to do that to the max. I think we have to, as I said, as NPHIs develop, you have to recognize how much you can take on at the same time. There's a lot of more basic or more primary health security related issues that need to be tackled to the full. So I do not need to compete with the HIV/AIDS program or with the TB program to take on their jobs. Actually, I think they need to continue what they're doing, because whether we like it or not, they have had significant benefits on the response to those conditions. Yes, we might focus on, there's been verticalization or not, but there's been a lot of cross-cutting development, especially as all of these programs moved on in their journeys to provide health system strengthening funding. So that's that. And I think that these cross-cutting approaches provide opportunities for better synergy, including the efficiency, coverage, and scale of NPHI activities, and they are necessary. Absolutely necessary, given the current and future threats to public health in all of our countries. So as we say back home, we will, and indeed we must, keep pushing onwards and upwards. Thank you all very much.
Thank you for that. We'll hold questions toward the end for the panel to give the perspective of the academic institution, but also the implementing partner. I'd like to welcome Dr. Lashley Abimiku. She is the Executive Director for the International Research Center of Excellence at IHBN, and also a professor at the University of Maryland, Baltimore School of Medicine. Again, very long list of accreditation, and we're running out of time. And she is wonderfully going to talk about an area of supporting the NPHI. Welcome, Lashley.
Thank you. Thanks very much. I just mentioned to Dr. Adetifa, the Director General of NCDC in Nigeria, that he's just made my job really much easier, because it is a pleasure to be here, in person, and to participate in this conference. That's really an opportunity to network and work together. And I believe that some of the comments that were made this morning by Roger Glass is really appropriate for some of the discussions that I'm going to have, because it really emphasizes partnership that we need to form. And why Dr. Adetifa's talk has made mine much easier is, in this partnership, we really have to look at the national public health institutions and the NCDCs to provide guidance. And my role here is to provide that example of how University of Maryland, working with a local NGO, the Institute of Human Virology Nigeria, has been able to support the National Public Health Institute in Nigeria. So I'd like to start by just giving you a little bit of a background in terms of this partnership. In fact, building on what Dr. Yilda just eloquently presented as the cornerstone of Ambassador Kingerson's principles, is building on PEPFAR in 2004, University of Maryland really established the partnership that included building capacity and also investing in the individuals in Nigeria. And so with the PEPFAR program in 2004, there was a significant partnership that was formed between University of Maryland, the Institute of Human Virology, and the individuals in Nigeria, and hence the institute that was built in Nigeria that now became its own NGO in 2010 is named Institute of Human Virology Nigeria. And in fact, the Chief Executive Officer, Dr. Dakum, is in the audience. But as a University of Maryland, one of the things that we really engage in is using research and later on implementation science to ensure that we also benefit from providing some insights in terms of some of the health challenges within the countries that we operate. And in 2016, the University of Maryland Institute of Human Virology School of Medicine plus the Institute of Human Virology Nigeria decided to set up a research arm, which is named the International Research Center of Excellence, which I direct. And that really gave us an opportunity to take advantage of all of the infrastructure and the cohorts that present public health challenge and work together with the government and other institutions, universities, and research institutions within the country to look at that. So what has happened in the next few years is that local NGO, the IHVN, Institute of Human Virology Nigeria, has been able to develop an infrastructure and dedicated a whole twin tower building that would support a research agenda that was relevant to the government of Nigeria. And that research agenda built on the capacity that was presented by PEPFAR to further strengthen facilities, but also to develop clinical trial unit and core laboratories that would allow the kind of implementation science that is required, and more importantly, also a biorepository. And that has been really significant in being able to use all of the experiences that we have had in setting up a biorepository in the country, despite the challenges, especially with power, to then now support the National Public Health Institutes when it was ready to put up maybe one of the largest biorepository in the country. And then, of course, all of the operations that is required is now housed in Tower A to ensure that all of the funding adheres to the regulations of sponsors. So what I'd like to do in general is in the next few slides to give you an example of how some of those opportunities has really built and leveraged on the infrastructure and the capacity that has been built by PEPFAR. So some of this have involved really strengthening the workforce so that we've got trained clinicians, trained laboratory personnel, and data analysts and data clerks that are able to work and really present high quality activities and interactions with the different cohorts. We've strengthened the infrastructure, like I mentioned, whether it's the health facilities or the laboratories that are involved in the diagnostics. We have built on everything that PEPFAR has done in terms of serological and molecular capacity that, as Dr. Adetifa just mentioned, can be expanded to other pathogens as well. Really paid attention to all of the quality systems that need to be established within the country. And that quality system is relevant to HIV as much as other pathogens that are coming down the line. Very important, especially for pandemics and the National Public Health Institute, is the fact that under PEPFAR we've been able to establish highly contained laboratories that have BSL-2 and BSL-3 capability that can handle also pathogens of unknown origins. And then more importantly, the fact that because of the structure within the country, under PEPFAR, there was an effective sample referral system that has been set up, and then we've used that to leverage in order to establish an integrated sample referral system where other samples can also use that network within the countries. And more importantly, the data management systems, the ability to collect clean data, to house that under the national program and be able to look at what is happening nationally. So we've used all of that infrastructure to really support some of the activities that is required by the National Public Health Institutes. And one of it is setting up the National Biorepository. And an example of that is really in the fact that Nigeria, Dr. Adetifa mentioned this as well, has implemented probably through University of Maryland, and in fact, Man was the PI for that NICE population-based survey on the impact of AIDS, probably the largest survey that has been done globally, and that has involved over 383,000 participants, and fully establish the HIV prevalence and mapped it within the country. So what you see in the dark shade here is the concentration of the pandemic, so that now the limited resources can be really focused on that. Now, when we look at other pandemics, all of the specialties and the capability that you need for household surveys, for all of the laboratory infrastructure and the data management and the biorepository is all going to be relevant for any pandemic or outbreak that we're dealing with. And this was all built on the backbone of PEPFAR. So right now, with the national biorepository, with an incredible amount of biosamples, over 1 million, one can now go back and also test for other unknown pathogens that one may not be thinking about. In addition to that, what PEPFAR has also provided are samples, what is called remnant samples, that is coming from the viral load testing and for the from early infant diagnosis, because that is collected at dry blood spot, available to test for other pathogens that of concern that the National Public Health Institutes have set up. So this really valuable infrastructure and training that has been set up by PEPFAR, and these are examples where now the Institute of Human Virology Nigeria is supporting the NPHI to really begin to use those valuable platforms and biospecimens to look at some of the pathogens that are circulating in the country, or that may be, or that are showing trends of the fact that they may be of concern in the future. So very quickly going on to the global health security as well, is the fact that SARS-CoV-2 has really taught us a lot about the importance of working in partnership and using a lot of the infrastructure that has been built already to better understand what's going on, and also to evaluate some of the control strategies that we've had. And Dr. Adetifa just mentioned a bit about the acute febrile illnesses that we're not too certain about what is happening over there. So again, through the acute febrile illness surveillance survey that we've done in the country, it's given the NPHI an indication of what other pathogens might be of concern, or at least to look at the trends within the country. And in this pilot, funded through CDC, we've been able to establish epidemiological information and set up all of the infrastructure that one would need to really look at acute febrile illness within the country. And so within the year that we have operated this in the selected states, we've been able to get data that now begins to point to some of the issues that are relevant to the acute febrile illnesses that are seen in the country. But more importantly, all of the operations and all of the tools and the platforms that need to be operational within the country has really been piloted. How the health facilities work with their epidemiologists and clinicians within the facilities, and how all of the samples within those facilities are tested using the rapid test that is available, but now transported effectively and tracked during the transportation to a reference lab, and further tested using the molecular platforms that have been set up by PEPFAR to look at other pathogens. And some of the other pathogens that we've looked at are listed on this slide, and the capability of really testing the pathogens have always been, that have also been tested. So really just by looking at this pilot, we've been able to point out that there are some other pathogens, apart from the general ones that have been looked at, that we can pick up from this acute febrile illnesses. And some of this is listed over here. And then in some cases, we're beginning to see also infections within an individual that is as a result of multiple pathogens. Obviously, in an endemic place like Nigeria, with malaria is really important. But again, we're seeing other pathogens like dengue, chikungunya, obviously Lassa is there, and then monkeypox. Monkeypox is something. Using all of that infrastructure that has been set up by under PEPFAR and using the sample referral system has worked really well to look at these additional pathogens as well. So in terms of data has always been a challenge in working in low and middle income countries. Just the ability to train enough people, to have the capacity to not just to collect good data, but to also be able to analyze it and be able to share some of the information that is coming from the country. So again, building on the national data system, we've been able to strengthen it such that all of the information that has been harnessed on the HIV also can be harnessed for these other different pathogens, so that it is possible for identifier to begin to see the trends of these pathogens that are coming into the country as a result of from acute febrile illnesses. And so the ability to have real trained epidemiologists, data clerks, data analysts, statisticians within the country is absolutely important in the partnership that we build in those countries. So in the interest of time, what I'll do is just to share with you some of the lessons learned from the work that we've done under the Institute of Human Virology, Nigeria, in partnership with University of Maryland, Baltimore. And very importantly, some of the points that I have made during my presentation that is also summarized here. The fact that the acute febrile illness could set up a surveillance system that builds on the capacity of HIV and TB, but that tells us a lot about other pathogens. And utilizing the infrastructure that has been set up on the PEPFAR, and really building on those systems as well. Of course, one of the things that University of Nigeria has done in terms of working with the NGO in Nigeria, the IHVN, is really to build also the capacity of the NPHI, But these NPHIs within the continent, they're really very similar. So for the University of Maryland's global program, it was really important that with the other African countries that they've worked with, that they work with, that we take the experience and the lessons that we learned in Nigeria and apply that. And one of the countries that we've successfully done that is in Malawi. And the next speaker is really going to give more in terms of what the Malawian National Public Health Institute is about. But just to point out the fact that some of the lessons learned from Nigeria that we've used, building on the infrastructure that has been set up by PEPFAR, has also worked greatly in Malawi, where we have the traditional laboratories that have been set up for HIV and early infant diagnosis, also doing the drug resistance for HIV, being used to detect SARS-CoV-2 and help the country in really monitoring the pandemic as a result of SARS-CoV-2. And here are all of those technical expertise that are already very familiar with doing the sequencing on the HIV, now using that technology to address another RNA virus that is of concern. But in addition as well, all of the gene expert point of care platforms were also put to very good use to address SARS-CoV-2, and this has been an incredible resource for the country in terms of really rolling out and knowing what is happening. And also the sequencing labs now are following all of the waves of SARS-CoV-2 and looking at the variation of the variants that are coming into the country. So with that, I'll just acknowledge all of the individuals, institutions, universities, sponsors, and especially the national public health institutions in the government that have been very supportive of the work that we've done in Nigeria and the ones that we're doing in other countries. And I look forward to discussing some more during the discussion session. Thank you.
Thanks, Lashley. So for our next speaker, I'll introduce the acting director for the Public Health Institute in Malawi. A lot of our work also have been south to south and now building the Malawi response, not only for HIV, but also pandemic preparedness. I'd like to introduce Dr. Kagoli to go up to the stand, please. Thank you. Welcome, sir.
Thank you, Prof, and my fellow panelists and participants. I'll talk briefly about it's like a case study, the COVID, HIV, and the Malawi National Public Health Institute. A lot has been said by the previous speakers. So just to mention, this is how, of course, I'm going to approach it, just to give a brief situation, like to attach the figures to what has been said about the National Public Health Institute and the HIV itself, and the interaction between HIV and COVID-19 that was there, and of course the role of Public Health Institute of Health in Malawi, the role that it plays, where is its place in all this. So essentially, HIV, as I think the first speaker said, it's a pandemic in itself. Of course, you can argue about it, but at least it was a pandemic. It still is, because now 2/3 of the cases in sub-Saharan Africa, 38 million people are still living with HIV. It's still a huge situation, so we shouldn't forget about it. It's still a significant cause of morbidity and mortality in Malawi, as we can see from the graphs there. It's quite an important thing. This is what I was saying. It's quite a huge, significant cause in terms of mortality and morbidity. In terms of when we look at the trends, it was worse in the area periods in the early 2000s. I remember then when I was still a young doctor going into a ward, and you see all these patients. They are HIV related, and there isn't much that you could do. You go around, you realize you couldn't discharge anyone, but you know that a lot more will be coming in. It was quite a terrible situation, but thanks to the available ARVs, the situation has improved. So we can see, I think, the graph on 2010 and 2023, the significant improvements that have been made. But as I said, this is just to give the figures in terms of the HIV situation in Malawi. It's still quite a huge health situation. Around 29 million people of the population, about 1 million of them are HIV. They are living with HIV. So it's quite significant. We can't really run away from that fact. And we lose about 11,000 lives in a year due to HIV. This is quite huge and significant. I'm trying to move away from this slide.
Maybe Dr. Kukauli, because I know that we're also running a little bit of time. I know it's very difficult.
This is just the situation in terms of, we have made quite significant advances in terms of the 95, 95, 95. Just to mention that, I think there are just slight, it's been achieved in terms of when we analyze the data on the ladies. Of course, there are some small gap in terms of the male targets and the significant gaps in the pediatric society. So there are a number of strategic interventions that are put in place to address the HIV situation in terms of the prevention, the testing, the treatment and care. As I said, it's quite made a huge difference. TB, HIV co-infection, addressing the vulnerable populations, and of course human rights issues. All these have contributed to the tremendous strides that have been made in the HIV. This is still looking at the trends when you look at 2010, 2023, and even when we try to project and look at 2027. A lot of people be living with HIV due to ARVs. This is a good thing in a way. It's a good thing because we are saving lives, I should say. Because of all these interventions, as we can see, there is, as I say, a lot of people will be living with HIV, but however, the trends in terms of incidence, there's quite significant trends in terms of the new people that are getting infected. And as I said, we're also losing quite very few people to HIV, which is quite good. So what's really is the intersection between HIV and the COVID-19 itself? So before the COVID-19, we had our own projections and ambitions in terms of the HIV situation in the country, and we're on trend to end HIV as a public health concern in the country by 2030. We still are, to a large extent, on that trend. And of course, COVID-19 impacted the service delivery. It overstretched health service delivery in terms of the human resource. A lot of patients came in and the human resource couldn't cope, and even the commodity, the supply chain was affected. We remember most countries had lockdowns. All this impacted on the delivery of health services in general and the HIV in particular. And of course, there was an impact on the global transportation system, which affected the country level supply chain. And of course, though the viral load, we did a study, Dr. Toko Kalua did a study, the viral load was maintained during the COVID-19 pandemic, but some indicators were affected. So while in general the provision of health services was maintained, as I said, some services were suspended, routine viral load testing was suspended, voluntary medical male circumcision, condom distribution. All these are interventions meant to prevent HIV, and they were impacted by the COVID-19 pandemic. So as I said, a number of interventions were affected. This is just look at the total tests that were conducted in the Q1 2020 against those in Q2. We can see there was a decline in terms of HIV testing that was observed. This is just look, there was a 32% decrease in the new initiations, that is in terms of ART. We can see a general decline. Of course, it might also be a result of saturation the HIV program has been around for quite some time and offering ARVs. There can be an element of saturation, but we can see when we compare in terms of the projections and what we actually had in the COVID era, there was quite a significant reduction. As I mentioned, there was no significant changes in the viral load suppression. So what's the role of the Public Health Institute itself? This is exactly, it's just a mirror image of what is happening in Nigeria, possibly at different scales. Nigeria is a huge country, so the scales might differ, but it's a similar situation in terms of our roles and what we stand there to do. This is just to look at the complementarity of the Public Health Institute itself and the HIV department. They are quite complementary in terms of what they stand for. And this is just the structure of the Public Health Institute. Just to mention that in the epidemiology unit that is within the Public Health Institute, that's where we have disease surveillance, that's where we have the issues of Public Health Emergency Operations Center, that's where IHR International Health Regulation 2005, the Global Health and Security Agenda are housed. So it's got that critical role when it comes to pandemic preparedness and response. This is just how we relate in terms of the COVID-19. We were the technical arm of the ministry responding to the COVID-19, reporting to higher bodies and the structures in the government of Malawi. But this is just to show the place that the Public Health Institute had in terms of the response to COVID-19 itself. Of course, these are the different functions in terms of the public health, the film itself, and the health cluster, and the presidential task force that was set up to coordinate the response to COVID-19. This is just the situation in general in terms of the numbers. All the countries really experienced COVID-19. Of course, we had challenges in terms of testing, so our numbers may not be a true reflection. However, I think the numbers in terms of the deaths might really measure up to what really was the problem. These were the interventions that were being implemented, quite similar to most of the countries that they were doing in terms of the response to COVID-19. So in response, I should say that we are looking at what the COVID-19 did to HIV response, but we should also appreciate that a strong HIV program really helped in the fight against COVID-19. It's now easier to talk about positive political leadership, but before HIV possibly it was a different story. HIV brought it up, brought the leaders on board so that they become aware of the health situation and their role in the fight on health issues. As it has been said, the laboratory infrastructure was used in terms of our COVID response, and of course in-country funds that were already there to fight HIV were repurposed and used to fight COVID. And of course, the HIV, the community that was already built by the HIV response was taken on board in terms of the religious and the civil society organizations. They were already sensitized on health issues, so it was easy to take them on board to join the fight against COVID-19. These are all positives that were drawn and they were harnessed from the strong HIV program. So yes, I think while we can say that the public health institutes have a role, but even our own response to HIV helped in a way to fight the COVID-19 pandemic. So this is just in conclusion to say that pandemics will come and will overstretch the healthcare systems, and obviously governments will do anything to respond. They have a responsibility when it comes to public health and security. So I think really the main way is to partnership, as has been said before, and we can never emphasize on that, to partner and fight together everything that we can. So this is just to acknowledge the people that helped me in the presentation. Otherwise, I thank you very much.
Thank you. Thank you, that was great. Wonderful presentation to give perspective. So I'd like to spend the next 15 minutes, we'll entertain questions from the audience as well. If you do, there's 2 mics in the center of the room. So we'd like to be able to talk about how this intersection between HIV, pandemic preparedness, also from a perspective of donors, programs, and academic institution will help kind of merge for the synergies. Yes.
Hi. Oh, I don't think this is on. Do I turn this on?
Is the mic on in the middle?
Hello. Oh, great.
Wonderful.
Okay, thank you. Thank you for those excellent presentations. It's very interesting. For the colleagues who have done this outstanding work in Nigeria, I was curious about how the funding structures are led. It looks like there was an initial grant, I think the PEPFAR, that was led by the colleague from the University of Maryland, and I'm wondering if that ownership of funding, developing the funding, applying for it, has transferred over to Nigerian colleagues. If so, how did that actually work? And are you getting the same indirect rates as the US partners were getting on those grants? Thank you.
Great. So who shall take that one? I think lastly, maybe if Dr. Aditifa has follow-up, we'll certainly do it.
Hello? Yeah. Can you hear me? Yeah. Thanks for the question. The partnership between University of Maryland and Institute of Human Virology Nigeria, as you can see, is a long-term partnership. So the transition has been phase-like, where at the beginning there was integration of faculty from University of Maryland in Nigeria, working with colleagues in Nigeria until, I don't know, 8-10 years later. The institution in Nigeria is its own standing institution with its own board, but the collaborations between faculty at the University of Maryland and in Nigeria continued. They're responsible for their own funding. In fact, now we have situations where faculty from Nigeria are getting their funding and involving faculty from University of Maryland. They manage their own funds, they're audited, and sometimes they sub to University of Maryland. So it's all self-standing. I hope I've addressed the question.
Yeah, perhaps Dr. Aditifa can talk about the synergies between other implementing partner and NCDC, perhaps.
Well, thank you. In terms of the funding streams, they're basically a hybrid or multitude of approaches. So we do get direct funding into our coffers that we manage depending on the project. We've got several, for example, we've got several CUGHs with the US CDC or non-CUGH agreements as well. For some other projects, they are run through, funding is run through the implementing partners or through other fiduciary platforms just to make sure grant negotiations and signings are as easy as possible. We do, especially since July last year, we do have an indirect funding or cost rate of 15%, which has to be costed into the grants, regardless of who is actually managing the funds. But that is our budget, and we expect to receive those towards the operational cost, especially the challenges with electricity, with the internet, and so on and so forth. Well, just to say, well, that's what we ask for, but I know, for example, the US CDC doesn't pay more than, so we take the maximum the US CDC offers, and there is room for negotiation, obviously, to make sure that nobody's running against their own institutional rules, as the case may be.
Yes. Is there a question in the middle there?
Yes. Thank you very much to the excellent panelists. So, and to say thank you very much for those excellent insights. So my question goes to Dr. Adetifa. I wanted to find out, when you made a presentation, you spoke about the action plan for health security that runs from 2018 to 2022. So I wanted to find out if there's a plan for a new one that will run from now till maybe the next few years. And then perhaps, are there lessons that you learned from COVID, that you would want to include in this new strategy or policy document? Because I assume as at 2018, we didn't have COVID, right? So were there things you wished were in that past policy when you had to deal with COVID that you want to make sure are included in the new policy that you want to develop? So basically, what are the lessons from COVID that we're going to take into a new policy? The second question is with regards to taking a systems strengthening approach towards the work, especially in light of the new ambassador's PEPFAR strategy. So you did mention something about strengthening systems through laboratories. I wanted to know, are there perhaps other ways that in partnership with PEPFAR, you're using a system strengthening approach towards health security? Thank you.
I hope this. Okay, it's almost. I almost feel like I'm in an oral exam, but anyway. So thank you for those questions. The first one, yes, you are right. There is a new action plan for health security and development. Earlier this year, the necessary meetings to review, monitor indicators, and identify gaps were done, and that's a continuing process. It's behind, obviously, because we had the distraction of COVID. Ideally, the strategy to come into fore from 2023 should have been developed last year, but we still have a COVID hangover, and that's despite not having anything near the kind of scenario that was experienced here. But that's already in progress. In terms of the lessons taken forward, I think, so I've spoken a few places about emergency preparedness and response, and I suspect the situation is the same in many of the countries in our part of the world. So we need to do more in peacetime. That's the big lesson, really. All that preparedness work needs to be really done in peacetime. And often we do not get, so once the crisis is over and people move on to the next headline or next challenge, you do not get as much of the traction that you want in terms of those who are holding the purse strings to understand that you need to put things in place now. So you need the laboratory systems to work. You need them to be linked to clinical care so that basically every potential patient who comes up with something that might eventually become a public health threat is correctly diagnosed as part of their clinical workup, okay? So it means you need to have laboratories in place, training, consumables and all of that in place. And often people who control resources tend to be more in a crisis road. They respond when the knife point is right in front of their eyeballs. And I sort of liken this when I'm speaking to people that we need to sort of pay the large premiums for comprehensive insurance, because whatever you do, they're going to be a lot cheaper than trying to replace your building, your house, or life, as the case may be. So this is something we need to take forward, or we hope to take forward. And one of the other things we learned, obviously, is that the budget for the action plan is really not adequate. There's a lot more to do to address the gaps in-house. The challenges related to the workforce that need to be, the healthcare workforce in general, but even the public health workforce that needs to be addressed comprehensively and in more detail in the next plan. Things like what happens at community level in terms of surveillance, all of the event-based surveillance that make up your early warning system, these need to work. So we've got differences in performance at national versus sub-national, and the lowest sort of maybe county or whatever we call them local governments where we come from. And we need the same capacity to permeate at all levels. So one of the challenges or areas of strategy that we've identified that needs to be addressed going forward is actually sub-national health security. And we have a program of work around sub-national JEEs to make sure that our state elements actually understand their contribution to national health security, because whether you look at it from the perspective of a country or globally, we will only be as strong as our weakest link, really. So that needs to be addressed. But those are some of the lessons that we have learned in the context of COVID and other outbreaks that we've had to deal with. And we will, we intend to take them further. If I backtrack a bit, also, if people didn't know, health security or national health security is not just a health matter. So I've got to deal, apart from One Health players, so we need, a lesson there is that we need the One Health coordination to work better at all levels. But you need to deal with people who control water resources, for example, and the like as well.
Thank you. So perhaps just the time management, maybe two more questions. And please, I forgot to ask the question to also introduce yourself as well as you ask your question. Thank you.
Good afternoon, everybody. I am Benita. I'm from Johns Hopkins University. I work in a project that is funded by CDC that is doing strengthening of National Public Health Institute in mostly Western African countries. So my question is related to the experience from that work. I understand the NPHI is a relatively very new institution that is carved out from the broader work that Ministry of Health traditionally has been doing. So I'm curious to know from colleagues here, what has been the relationship like with the Ministry of Health, and how that relationship or perhaps a collaboration at this stage been working in terms of achieving some of the vision that you've set for your institution. And you began to talk a little bit about the workforce issue and the subnational level. Perhaps can you speak more about, I guess, do you have your own workers working at all levels of the government, or do you work with MOH, and how do you see that collaboration being fostered moving forward? And I guess the other question, we talked a lot about partnership here, but in terms of leveraging new partnership, I know traditionally institutions go directly meet with MOH, and then that's where the partnership begins. But have you been independent enough or strong enough to leverage the partnership on your own? And has there been any challenges on that regard as well? Thank you.
Thank you. I think that's a wonderful question. Maybe perhaps Dr. Kagoli can give a perspective Malawi on the PIM and the MOH. I think that would be meaningful to hear.
Hello. Yeah, I think for Malawi, it's really a relatively a young institution. We are still part of the Ministry of Health, so maybe we don't have some of the challenges that the Nigerian CDC may have. But just to mention that it's the appreciation in the country. It's a continental drive, the appreciation that we need the national public health institutes to kind of coordinate this agenda in terms of the response to public health emergencies. So when the country buys into that and they appreciate that, then they view the national institute, like in our case, the Public Health Institute, as a technical arm of the ministry on this platform. So from there, then we are working together from the outset. There is that kind of linkage and understanding right from the start. So that when talking about partnership, it really, it's like charity begins at home. We are starting from there. Then we are building in with the other partners to move forward. So it's not really like having very specific employees at the implementation. It's still the Ministry of Health doing the implementation. It's more of the coordination and making sure that we are responding accordingly. Maybe that's how I could go.
Well, yeah. So I did say earlier that the NPHI agenda, especially in our part of the world, has countries in different sort of stages in the evolution. So you still have, you may have no NPHI. That's the ministry looks after anything that NPHI should do. You have what we have in Malawi, where there is NPHI was still operating as a unit within the ministry. And the Nigerian situation where you have NPHI with its own enabling law, which actually was only signed in November 2018, so we are less than 5 years old as an independent running entity. But having said that, we're still an agency of the Ministry of Health, okay? But yes, we have the independence to hire staff. So we've got our own separate staff. As part of the separation process or budding off from the ministry, people in the units that were collapsed to make the NPHI were offered the opportunity to stay in the ministry or move on to the new agency. And some did, some stayed. But we've also had recruitment rounds. We also have our own independent budget, which of course is within the envelope given to the Federal Ministry of Health, but still separate, and which I have to account for in terms of even the expenditure and all of that. We have the independence to enter into agreements with partners. Our dealings with the IHVN or University of Maryland affiliated entities and others is completely independent of the ministry, and for other things that they do, they actually can also speak to the ministry directly. So I hope that answers the question. But I think it's important, especially given that there are many people here who may be jumping on the NPHI train, that it is absolutely important that you recognize country context and where they are. You cannot come with the idea that you want a new US CDC in a particular country or UKHSA or whatever. So countries will travel. But I think what is important is what my colleague has said is there is no doubt, I think in all conversations, given COVID and others, people recognize the importance of NPHIs. It's just that the setting them up, equipping them to run, even having the human technical capacity as required in the public sector with competing demands for resources and all of that requires a bit of time and travel and evolution and growth. And even us, we are still growing, still struggling with challenges of being an under 5.
So I think with that, I'd just like to thank the panel, but that I think we all recognize that the NPHI are really the frontline institute. I think Dr. Yila and PEPFAR do have a lot of work ahead in front, but I think there are a lot of opportunities as well. No matter which sector we're all from, I think there's a great opportunity to support the NPHI because they are the frontline institute that is really required in peacetime and in wartime. And obviously, thank you for the perspective of the panelists as well. And if you have any questions for them, please approach them after the panel. And I thank you and I apologize that we dragged on, but really thank you for your attendance today. Thank you.